and this is MED260 class exams and specialty procedures. It is now 9 a.m. Friday, October 23, 2020. Happy Friday. What is due today is, of course, your discussion one and quiz one. There's no other things due today. And in order to garner, what do you call that? Attendance, you had to have done something during the week. And in order to garner full credit for your lesson, you either have to be on this call live, or if you were not able to make it, shoot me an email so I can give you an alternative assignment. Last week we talked about basic history taking, and I left it up to you guys to look up preparing the exam room. Here's a classic example. I haven't been on campus in the last week. Everything's upside down. Um, Always, and I'll be talking to my counterparts regarding this matter, because you always leave a room better than you came in. So everyone shares the facility, and I can't discount this too much, because that's how you get into compliance issues. That's how you run into needles on the floor, that kind of thing. I mean, it wasn't that bad today, but chairs are overturned, things are, and it looks obvious that someone used the laboratory and did not put it back in its same place. And of course, I'm here on Fridays. I wanted to also check the compliance of the laboratory. And those are habits that I've had all the way since I was a medical assistant. But it's not surprising to find that it's just like driving. You start off really, really doing well in driving and following all the rules. But after a while, what happens? It's a slippery slope, and you start doing less and less and less, to the point where you leave a room worse than it was. And same thing for equipment as well. um, uh, um, I'm sure the last person who used something was like a week ago, and the printer, everything is broken, and I have no. He goes, I have no idea who did it, who left it like that, and you'll see in a hospital setting, it's not only annoying. Let's say, for example, you have an emergency case or an urgent case. If the room isn't prepped and isn't and everything is in its right place, then it's going to have some issues. You're going to have a hard time managing your patient. Now, history taking is part of, we talked about the SOAP last week, subjective, objective, assessment, and plan. So history taking is the subjective part. So I could ask you on an exam, my patient's 12-pack year of smoking, is that subjective, objective, assessment, or plan? And it's, of course, the subjective portion. Now, what are we going to be talking about this week, which is more related to the class as a whole, is the objective piece. Now, if something is objective, it means that it's an object. We all can see it. So the physical examination and the ensuing laboratories that we do to confirm diagnosis, that's all objective material. Meaning to say is, like, if my patient has a fever, it's like a sign, right? Symptoms are how the patient feels. A sign is the things that we see. So for example, my patient feels feverish. That's subjective. I got to take it with a grain of salt. They could be lying, they could be exaggerating, or I could have asked I could have asked the question wrong. But in the physical examination, which vital signs are a part of, if I put that thermometer in your mouth or in your ear, or that newfangled one that they shoot on your forehead, which, by the way, could be plus or minus 3 degrees off. I don't understand why we use it. And also, again, back to data. Is there any data that anyone who's even COVID positive or pre-COVID has a fever? that's also the funny thing about, you know, and again, I mentioned it last week, and the guru, Dr. Fauci, said we can no longer separate politics from science, and it's a sad thing. This morning, I put my youngest one on the bus, and he was fussing, and because of the thermometer, and I'm thinking, I'm thinking he could have Ebola, and you guys wouldn't even know. But again, rules are rules and we have to follow them. So let's look at the rules of the physical examination. And I have some notes here on, and a little video here on how to set up an exam room, which is, you know, complementary towards last week's stuff. So let's go in the physical examination. Let's go in your textbook. And let's look at the chapter on the physical examination. And the outline, again, I have to say this as a public service announcement. The outline is of your textbook, but an older version of your textbook from like 3-4 years ago. And the pages may or may not match. No, who am I kidding? The pages won't match, right? So you look up the pertinent chapters. So we're looking up physical examination. So we're going to go in here in clinical practices, in this little arrow, infection control, patient interview, and we're going to start here, chapter 38, the general physical examination. Now you could see here, I'm going to go over vital signs separately because that I'm gonna probably talk about that maybe a little bit later, because that's the thing that we have to practice in our laboratory. But the general examination, that is that's the physician or the clinician's job. So let's first look at this case. Valerie Ramirez, and again, it's missing her her age and her occupation, because remember, the age, it tells us certain things and certain pathologies that we should be looking out after. And occupation also leads us down the road of when we're investigating what's the main issue of our patient. So she came in. So the chief complaint is general physical examination. So odds are she's asymptomatic, nothing really going on. She just came in for a physical, and 9 times out of 10 is usually because of work or an insurance or insurance company approval. And be wary of that, because they tend to, I used to do, before I got my residency, there was a year where I was kind of like waitlisted. So for a year, I did insurance, general physical examinations and EKGs and blood work for this company called MED260 out of New Jersey. And we used to do physical exams. And when I'm interviewing the patient, it's amazing how much they lie, because, and the lies got bigger if the insurance was bigger. So if it was the insurance was only for like $250,000, most of my patients would have been, they're honest. But when it got to like the millions, they start lying through their teeth, like, oh, I've never had a drink in my life. But again, we only take what the patient gives us, and we write on the chart patient claims when it's obvious, like, you know, they're kind of lying to you. How many, I had a grand obese patient. He was maybe 340, 350 pounds. And he was trying to tell me that he ran 30 miles a week on his treadmill at work. But I wrote patient claims, runs 30 miles a week. But on my physical examination, I'm going to put down all the data that I can see, and that's all the signs. So Valerie Ramirez came in for the general physical examination, hadn't had a physical for the last 3 years. So we're going to have to do blood. We're going to have to do, she looks relatively young, so we have to do gynecological screen. Now, when I say the word screen, let's look here. There's 2 basic kinds of tests. You have a screen and you have a definitive. Now, a screening test, that's a test usually for an asymptomatic patient. It goes, if the screening test is positive, it doesn't necessarily mean that it may or may, the patient may or may not be, have what they have. An example is a Pap smear or Papa-Nicolau smear, also known as a Pap smear. Okay, so a Pap smear, its diagnosis is for cervical cancer and any other problems with the female cervix, which will be part and parcel of her obstetric exam, right? So let's say, for example, Ms. Ramirez has a positive Pap smear for abnormal cells. Then I have to do something, I have to now then follow up with a definitive test, and that's a biopsy. Biopsies are always the definitive test for cancer. Okay. Also, she could be like me and doesn't eat too well. And a screening test would be FBS or FBG, and that stands for fasting blood sugar or fasting blood glucose. Now, if you have an abnormal fasting blood sugar, it doesn't mean you have diabetes. But if you have an abnormal fasting blood sugar, then I'm going to have you come back, and the definitive test for diabetes mellitus is OGTT, which is the oral glucose tolerance test. And some of you ladies may have done that if you were pregnant, because pregnancy has, the FBS could be all over the place in pregnancy. The rule of thumb for pregnancy is everything could be abnormal or everything could be normal. It depends on the situation. Okay, and that's why in medical school there is a whole 2 out of the 4 years dedicated just for obstetrics. Obstetrics 1 and 2 in medical school. So she comes in, she also has an EKG. EKG is also a nice screening exam for cardiovascular cardiovascular things. But it goes, if things aren't good, we're going to have her come back and do a stress test. Her vital signs: blood pressure looks normal, 122/80. Temperature is 98.6 degrees Fahrenheit or 37 degrees Celsius. Remember when you do your charting to be specific. Pulse is 84 beats per minute and respiratory is 20. So it's all normal. Height, she's 5'2" and 140 pounds. So she has class 1 obesity, which is like 90% of Americans in this country. So she states she's feeling good, no complaints, and she just came in for the physical. So what are parts and parcel of the general physical examination? The first part is the vitals, but we're going to be going over that later. Okay. So what do? Why are we having a physical examination? Well, we know why already, because we already had that lecture regarding SOAP. It's part of the process. I talk to my patient, and that's my subjective. I have to get their point of view. Now it's time for me to look at my patient directly, and and I need it to then lead me to a diagnosis. And if you look at the word diagnosis, nice little review for you. Diagnosis. That's the state of condition of complete or thorough knowledge. And that's what? In order to get the diagnosis, right, which is part of the A, assessment, I have to have all my subjective data. I have to have all my objective data. And part of my objective data is the PE, physical examination, vital signs, and any other laboratories. So for Ms. Valerie Ramirez, I could ask, what are her objective data? Well, we're going to do a gynecological exam, most likely Pap. They have also some blood tests. We're probably going to do fasting blood sugar, CBC, and we're going to be talking about all these tests, and EKG, and we also did vital signs. So these would all be her objective data. and we're going to put that all together, and we're going to come up with a clinical diagnosis. And remember, the difference between diagnosis and prognosis, and the difference between a sign and a symptom. A symptom is how the patient feels. A sign is things that we see in a laboratory or your physical examination. Now, going into prognosis. Diagnosis is a state of condition of complete or thorough knowledge. Just as a side note, prognosis looks almost the same, but pro means before. So it's a state or condition of before knowledge. It's a prediction of, based on current data, how well you will do in a year, 5 years, 10 years. Okay, so it may or may not come true, but it's something that we should be wary about. So what is your role to help the clinician? And the clinician could be a DO, doctorate of osteopathy. It could also be a nurse, DMP, right? No matter it is, your function is, or we already talked about it, is to help the clinician get the data. And last week we talked about we have to prepare the room. So if you know that there's tests to be done, you have to get the material for those tests ready. And another thing that we also have to do is we have to keep the room safe. So if there's spills or any dirt or anything, and again, my message to you guys is the same as message as my externship students. If they ask you to clean a window or clean the windowsill or clean the lab, it is part of your job. Because like today, I had to come in early, and I'm not the cleaning crew, right? The cleaning crew only cleans so much, right? They do not have training in what to look for regarding OSHA, which is the Occupational Safety and Hazard Administration, right? Now, OSHA has its own department regarding laboratories, and they can come visit you at any time. So you have to make sure that everything is, is clean, because if I just left the lab the way it was, that means, because not only is it unsightly, if your laboratory or if your the office looks shabby, do you think patients are going to want to come back? It's also part of marketing. So, and it's the same thing. It goes, my laboratories, I like to keep them clean, not only because I have a little bit of OCD, but I don't like looking at it when it's upside down and it's ugly. And my personal life, I'm a typical guy. I'm very messy. You don't want to come into my office or my basement. It's just, it just looks, my wife always makes fun of me and says, I'm like a snake. You know how a snake walks around and just, dumps their skin? When I come home, I'm like that. There's a trail of socks and shoes, but in my professional life, everything has to have its own place. So PPE goes aseptic hand washing, and also all the little bits and pieces regarding safety. And that's actually what I did this morning before I actually even came into the office, because you want to be able to assure whoever's working in your facility that they're working in a safe environment. And also, by the way, OSHA could come in at any given time. They did it to us a couple of years ago. They came in like random, and they looked at all of our labs, 5 minutes. Same thing for nurses. They came in, board of nursing came in, looked at their laboratory, not even 15 minutes, and declared it, and because of its appearance, not only its appearance, it was actually clean. And not only clean, is disinfected and all that jazz. Another thing that you also have to do when you prepare for an exam is you should read the chart, and actually you should know who you're walking into. Okay, we've discussed before in other classes the emotional patient, and we also discussed the nervous patient. Remember, you not only preparing yourself for the examination, you're also preparing your patient for the examination. And like I always said, physical examination preparation, we're going to talk about that in a moment. So, skip. Positioning and draping. Okay. Some of you here probably already had training. Some of you are certified nursing assistants, and you know a lot about the basic rules of body mechanics. Because those of us who work in the field, especially CNA, you guys do a lot of stuff outside your wheelhouse. And one of those classic examples is when you guys have to pick up a 300-pound patient alone without the lifting team, because the lifting team's busy elsewhere trying to pick up a 400-pound patient. Right? So the basic rules of body mechanics, and you will also see the data on many CNA professionals and many nursing professionals. They have a lot of carpal tunnel. They also have a lot of back and neck injuries. And it's because of repetitive motion, but body mechanics will help with that. So you're always trying to lift with your legs. You always keep your feet apart. And in laboratory, I'll also show you how to do that in order to keep your patient safe when they're stepping up onto the scale, or which is one of the more dangerous transitions we'll be discussing in laboratory in about 3 or 4 weeks. We'll be talking about the transition from your patient from bed to their walking or to their chair modalities. Okay. And how many times don't follow the rules of body mechanics? Either you get hurt or your patient gets hurt. And both of those situations are not acceptable in our facility. So you could see here on page 790, there are exam positions. And I think I have either a video or a picture. And here are your pictures. Now, how easy would it be for me to erase all the labels and just put A, B, C, D, E, F, G? Okay. And how would I ask it? I would ask you, I would either do one of two things. I will show you the position and you tell me what's its function. Or I could tell you, we're going to do this and that test. What position would I now prepare my patient in? Because it's such a pain, especially when there's a newbie in the room, where I have to go in there and then I have to go do your job by informing the patient what's going on. Because it's really great, and that's where the nursing care experience comes into play, is to preempt your clinician so that everything in the room is ready and the patient's ready and the patient knows what's coming. So what's a sitting position, right? Again, refer back to this figure 38-A. Do you see the little stool there? And there are good ones with rubber stoppers, and also the really fancy schmancy ones are the ones that have these little pistons in there where when you step on it, it secures it into the floor. So that's sitting position. And the big thing about the sitting position is that, of course, I want my patient to be able to easily face me, and they're nice in a safe area. If they're in their gown, they have a drape. If you notice that, again, we have to give our patient our due respect, and also at least some level of privacy, because we all know, like, when you go to the doctor's office, even though I trust the doctor, when I personally have to disrobe, it puts yourself out there, not only physically but emotionally. So make sure you have that drape, okay? And we'll be showing you in lab if the patient is too weak to be unsupported. We can also show you ways where you can provide support without, because many of our geriatric and elderly patients, they get kind of insulted, like when you keep on touching them without their permission and things of that matter. And that's obvious. But you also have to make sure that the patient is safe and they don't fall over, because that's a potential for an accidental fall. Supine, also known as recumbent, and that's where it goes. Supine and recumbent, let's look at that. So supine is lying down, face up. Recumbent I go, they're interchangeable, so that looks like a beautiful both A and B picture. So my patient, and as you could see, they have they're nice in the middle, and you make sure they're draped. Again, for not only for the comfort, and also we all know hospital facilities, they like keeping the hospital cold, and it's for asepsis purposes. Dorsal recumbent, okay, let's look at that picture. Right now, dorsal recumbent is a little bit different than supine. Because I'm going to put my patients here like this, because most likely that, like, let's say for example, the doctor is going to do an abdominal um, 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 physical examination. We'd like, if the patient is in flat out recumbent supine position, when they're flat, it puts like a stress on the abdominal muscles here, and it makes it harder for me to go feel around their organs here. But if I put them in dorsal recumbent position, it loosens up all the abdominal muscles, and I could now feel around. Lithotomy position, that's easy, of course, stirrups. And with the stirrups, we're going to be talking about what are all the other things that you need. You need the light, you need the perfect position, and of course, the draping, very, very important. And we're going to talk more about that in specifics when we talk about obstetrics in a couple of weeks. Let's now go to Fowler's. Fowler's position, patient is lying back on the table. Now, if they're at Fowler's, okay, you can see here. The reason why we put the patient in Fowler's, 9 times out of 10, it's because they're having some trouble. They're having some trouble breathing. Okay, so and especially also for EKG. Have any of you maybe have asthma, or maybe when you weren't feeling well? How hard is it to breathe when you're like in total supine position? So we like doing Fowlers or semi-Fowlers, just a little bit elevation so that the patient can breathe a little bit better and be more comfortable. Now prone, let's look at that one. Prone position is just lying down face down, and I want my patient's arms and hands out of the way. Again, I have to palpate the sides of my patient's torso, and also I may have to palpate here in the axillary area as well. So we like to put them in that position. Sims position, right? That's when we have the patient lying down on their left side. Now, depending on how your doctor's office is, typically surgery, the physician likes to be on the right side. And same thing for internal medicine as well. But it's also depending on the layout, and also depending what my physician or my clinician wants to do. But typically, Sims position and a modified Sims position that we also use for anal and rectal examinations is, we'll be also again showing you this in lab. We have the patient's the leg that's touching the table will be fully extended, and the leg that's up here will be flexed. So it gives me a greater vantage point here for any anal rectal examination. Knee, elbow, and that's if my patient can tolerate it. And of course, proctologic position, which is, it's a rarity. If I'm going to do it like that, I usually have the patient stand and just lean over or bend over here on the table. And I typically remove that little step here that's on the examination table. So I could go and ask you like, oh, if I'm going to do a proctologic or a anal or rectal, digital rectal examination, what are some nice features? I could use the proctologic position, knee, elbow, or Sims or modified Sims. Doesn't that look like a beautiful all of the above question for future reference? Now, I don't like this prone position too much because, again, my patient I have limited access here to my patient's backside. But here, it's much better. And again, just also to make note, it goes, if I'm doing an inspection or a visual inspection, we're going to also talk about in laboratory and in the subsequent chapters about lighting. You may see that, you know, that gooseneck light that that most doctors' offices have, or they have that overhead light like surgery does, especially in the semi-surgical services. You know, that big bright light with the handle on it. We could have one of those in the office as well. Okay. Okay. There's other positions that they talked about. The two other positions were Trendelenburg, and let's look at that. Okay. And we use them. When there's blood pressure emergencies and also certain type of surgeries. But this is what it looks like. Like so. And you could see why it makes sense for Trendelenburg. Let's say, for example, there's a blood pressure issue, right? But again, that's just so that you know what it looks like, and also for drainage purposes as well. If we're doing GI and genitourinary surgeries as well, we can do it that way as well. But again, that's like the extra. What's the main thing we should be focusing on is, but you know, I can throw it out there just to see who remembers. The main ones are these ones here on page 791. So, examination methods. Okay. This is the order of what the doctor does to you, in theory. When I was in school, we would practice all of this on every single patient in outpatient department. In real life, again, just like everything in this world, and remember my driving analogy, what happens? In order for expediency and shortcuts, the doctor does all these shortcuts. So if you've never been through even half of these things, it's okay. You know, it's not like the doctor totally messed up or the clinician totally messed up. But this is, in a perfect world, if I had all the time in the world to do my general physical examination on you, I would do all of these. So the first thing that the clinician does is inspect. So we have to look at you. And I'm not only looking at you, I'm using all of my senses. How do you talk? How do you walk? What kind of words do you use? Also, what do you smell like? Your mannerisms, your hygiene. Have you ever met somebody, like, they're not saying anything wrong, but you just have this vibe that there's something wrong? That's called precox. I forgot what the whole term is. It's called precox observation, or precognitive observation. It's when you, especially you get that a lot with, you know, your patients who have mental illness or mental defect. You're going to find that there's something off, right? And we've all met these people. Heck, he goes, maybe when you met me, you thought that, thought, hey, maybe this guy's a little off, right? So that's part of inspection. The next thing we do is auscultation. Now, we like doing auscultation or listening to the body sounds first. Auscultation is done before palpation because, in theory, if I start touching you, it might set off some sounds, you know? So we like doing auscultation next. So auscultation is listening to the body sound. So the heart and the lungs, and we also listen to your abdominal organs. Have the stethoscope ready for your physician. Have make sure to disinfect it with 70% isopropyl alcohol wipes between every patient. And because you don't know, did the doctor let somebody, or the DNP, did they let somebody else use their stuff in between patients? So you, you must assume that that asepsis needs to be performed. Now, palpation. nowadays in this world of COVID, we have to, the doctor probably will do it gloved nowadays. Um, um, Me, because pre-COVID, I would have touched my patient. And what am I doing when I'm touching my patient? I am looking for um, uh, different. I'm looking for anything that's abnormal. And another thing that I'm doing in palpation is I am looking at my patient's face, because if something hurts and they're trying to hide it from me, you're going to see something called grimacing. Grimacing is like, you know, when they wince just a little bit, and then you ask them, hey, did that hurt? And then they'll always say, no, 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 you know, it's just a little tender. Or, and then I'll touch that area again, maybe a little bit deeper, just to see. And we always start superficially first, and then we add some pressure. Okay. Now, what's percussion? Percussion, of course, is not drums. I'm not playing drums on my patient, but it is this thing. Let's get a video, because this is like a
Fold on the outside, packed inside.
Hey, it's making me want to buy a
Elevated for
Nissan
every
Rogue.
family. How will you go rogue? The all-new Nissan Rogue.
Pretty car. Okay, good. Ad's over.
Hi, my name's Zach. This is Harrison. Today we're talking about percussion as part of the medical examination. So if you're a John Bonham fan, you're in the wrong place.
Percussion is performed by placing the middle finger of your non-dominant hand over the area to be percussed and applying pressure with your middle phalange. You then use the fingers of your dominant hand to tap, like so, producing a note that gives you a clue as to the nature of the viscera underneath. Things that are hollow or full of gas, such as bowel or healthy lung, give a resonant percussion note. Things that are solid, like liver tissue or nasty consolidated lung, sound dull. For example, this Star Wars Mr. Potato Head is hollow and hence resonant to percussion. By contrast, this copy of Leo Tolstoy's War and Peace is rather dull.
Okay, so everyone try this. What this, I assume he's a physician, right? Tap on your middle finger, just like he was tapping here, and do it on the fatty part of your thigh. And you'll hear and feel a certain note, right? Now, try that again on your knee. And you will see, and we'll go again, we'll play around again with this. And again, this is the clinician's job, not yours. But then when you do that, I'm sure the patient will have a like, what was the doctor doing? And you'll, oh, that's called percussion. They want to see if there's like pockets of air or pockets of dense tissue. And we do that on your lungs. I do that on your abdomen. So that's percussion. And you could see I do that after inspection, auscultation, palpation, then I percuss. Now, what's mensuration? Do not get a mensuration confused with menstruation. Mensuration is measurements, so heights and weights and all those things as well. So that's part and parcel of your vital signs and also part of your objective data. Now, don't take mensuration or measuring for granted. If the measurement is off or not done regularly, remember, because the clinical staff use heights and weights, right? And your measurement for calculations for meds. So they have to be updated and accurate. Remember, there is no such thing as a small or minor procedure in a hospital or in any clinical setting. Everything has its importance. You may hear this term scut. They may even call you a scut monkey. which is not a pleasant term, but SCUT stands for some common unimportant task. That is a misnomer. Nothing is unimportant in medicine. Every little thing is important and adds to our objective data so we can get an accurate diagnosis. And if we don't have an accurate diagnosis, the management is going to be garbage and my patient isn't going to get better. Okay? Now, last but not least, manipulations. We do a lot of that in orthopedics. And the big thing regarding manipulations is determining a joint range of motion. There's this thing called a goniometer. Let's show you that. It's like this little protractor. And you could see it in physical therapy. It's like this. And then they put it like on your joint, like so. And then it gives you an angle. See? And then you read it and there's like an angle. And depending on how much improvement or lack of improvement, it will change the orthopedics orders for physical therapy. Okay? So those are called manipulations. So what could I do in an exam? I could ask you, oh, Dr. Garais needs a stethoscope. What will we be doing? Oh, auscultation. Dr. Garais is looking at my patient up and down for the last 20 minutes. Hasn't said a word. What is he performing? Inspection. He's using his fingers to tap on his patient's stomach. Has he lost his mind? No. It's palpation. Dr. Garais needs to find out the range of motion. What's that called? Manipulation. Okay. Now, another thing about manipulations is there are certain movements that elicit pain or elicit some sort of reaction, and that also falls under manipulations as well. Okay. Now, when you're doing a general physical examination and you're doing these things, there's something called the head-to-toe assessment, and it starts where? Of course, in your head. And it moves its way systematically down, and then it ends up with a neurologic exam. And we'll be talking about the neurologic examination separately. We'll be talking about, now here are some basic things that are in your doctor's office, and you need to know what they are, okay? And there's nice little pictures here. And wouldn't that be an easy quiz? I could have this picture just be A, B, C, D, E. Now, we'll be playing with these things. This is called your diagnostic kit. We'll be playing with these two things, B and C, which is your ophthalmoscope and your otoscope. And remember, use your medical terminology powers. The ophthalmoscope is for eyes, and your otoscope is for ears. Okay? And look at this. They made a lovely checklist right here on what you would need. Okay? All right. So what are we looking for when we're looking at my patient upon inspection? I'm looking at their general appearance. And again, like I mentioned, I'm using all my senses. Okay. What do I see? What do I hear? What do I smell? Okay. And I'm looking how the patient's skin, is it dry? Is it cracked? Are they disheveled? Are they, does it look like they showered? Same thing with their nails. Right? Do they keep themselves clean? Head. The big thing I'm looking at in HEENT, which is head, ears, eyes, nose, and throat. I'm just looking for just anything that inspection-wise, right? Do they look like they sleep? Is there any abnormal glows? Are there any bumps that shouldn't be there? Okay. Neck. The big thing I'm looking for in my face and my neck is symmetry. Okay. And it's amazing how Department of Neurology, my mother from across the room can see asymmetry and pathologic asymmetry. It is she actually early diagnosed one of my sons, Nelson Hermie, with a stroke. And he was barely 1 year old, and she just saw a minor, just a minor change in his symmetry of his face, and she said, and something's up. And I took a good, I'm his father. I see him every day. Well, I tried to see him every day. I didn't see it. I didn't pick up, but it's the difference between 6 years of clinical experience versus 45 years of clinical experience. Well, at the time she had like what, 30 years clinical experience, and I had like barely a year. Another thing we're looking for is neck. If the neck is supple, meaning soft, everyone feel their neck, right? It should be soft, right? Especially the anterior portion and also the side of your neck. But if you have hypertensive crisis or a thyroid problem, it will be stiff. Or if you have a musculoskeletal problem or stress headaches, or there's a whole bunch of things that will make your neck like stiffen up. And that's what we're also checking. Another thing we're also checking when I feel around your body and your neck is I'm looking at the cervical chain of lymph nodes. Because remember, if I have any lymphadenopathies or like swollen lymph glands, it will lead me to start looking at infection within that particular localized area. Eyes, I use the pen light. I make you look up, down, left, and right to see if not only the muscles in your eyes are working right, I'm also going to see if there's pupillary constriction. And not only if there's pupillary constriction, but I want to see that both eyes constrict when I flash. And that's what I'll do. I'll cover one eye, but I'll be watching the other eye to do the same. And that's a nice test for your cranial nerves and your base of your brain. And we'll talk more about that when we talk about neurologic. Ears, of course, I'm looking for cerumen, redness, swelling. I want to use the otoscope. I want to see if the the tympanic membrane or the eardrum is intact. My nose and sinuses, I also use the pen light. I put it right on your skin and to see if your sinuses are nice and clear. Mouth and throat, again, I'm looking at the pen light. I'm looking at the teeth. I'm also, while I'm there, I'm also trying to see the smell, right? Also, I'm looking at the way your tongue lies when you stick out your tongue and the way you say ah, because neurologically, if your tongue deviates, it's probably deviating towards the side of some sort of pathology. Next, chest and lungs, of course, we're going to listen to it, right? I'm also going to look at symmetry. How does your back look? Okay. Heart, of course, I want the heart sounds. Breasts. Now, both male and female students, everybody on this call should be doing their monthly BSE or breast self-examination. And part of that is we do it all in my patient in not only the sitting position, they should also be in the supine position as well, because depending on how, because most female breast tissue has a decent amount of adipose or fat in it. And then when you lie down, or when you sit up, it might elucidate a mass, or it might be able to show a mass when I didn't see it in the other position. So remember, that looks like a beautiful both A and B question. When you do the BSE, what are the two positions we're going to set our patient up for? Sitting and supine. Abdomen, I'm not only looking for sounds, I'm looking for also consistency of, the things that I feel. The liver should feel like it's liver. Actually, I shouldn't feel my liver, but if it's sticking out of your 10th rib, that's a problem. It's called liver sign. I'm also looking at, again, your reactions when I start palpating you. I'm also looking for, what else am I looking for? I'm also doing it right here. You see the word quadrants. I'm also doing it in an organized manner, so I can see it. Male and female genitalia, of course, prepare your patient, right? Especially when the clinician tells you to have the patient disrobe, including their underwear. And if including their underwear, that odds are, right, unless the doctor wants some charges, right? We're going to be looking at this. Now, for male, it's either standing or sitting, right, with the patient and most likely we're looking for any signs or symptoms of any testicular CA. Now, with your female patient, we will be doing that in a gynecological exam. It wouldn't, the patient would be in stirrups. Digital examinations are important because there's things that my finger can feel, gloved, of course, right? And of course, if you know you're having a digital rectal examination, make sure the KY is already there, the glove is already there, everything's there. Because we do digital rectal examinations on male patients greater than 40 years of age because they're at risk for benign prostatic hypertrophy or prostatic CA. Okay, so we have to regularly look at that. Musculoskeletal system, I'm already judging that, the way you walk, the way you move around. I'm also looking at the symmetry, and if there's asymmetry, especially with the spine, you'll see that the shoulder blades won't line up, and if they don't line up, my patient has scoliosis. Neurologic exam, of course, we're going to be talking about that separately. Now, what other tests, procedures, and things that you have to talk about? And that's what the rest of this course. And we're going every week. We're going to go by step on each department on what's important. So right now, this is just the general examination. Here are at the end of all of your chapters are some really nice protocol sheets. And actually, they're just nice for you to know and understand that when you go to a facility, protocol is the steps and the proper steps to do something. And for example, OSHA and the Joint Commission, which is JCO, the Joint Commission on the Accreditation of Hospital Organizations, for short. So they look to see, did you do everything? Not only did you do everything, but in the order at which it is published in your protocol manuals. And every department has this manual, has this binder of everything that we do and in the order that we do it. Okay? And look at this rationale here when you look at these, because these are nice. These are answers to nice why questions for future exam purposes. How to position a patient. We'll be doing this in laboratory as well, right? I like this, the standing proctologic. And do you see where their arms are at? I put their arms on their chest so they can't stop me, and they're nice and stable. Because if I have their arms on their side, they could move and they could touch something that they shouldn't be touching. Commuting and factory, other cultures. This is nice. This is nice to know, right? We'll be doing this and practicing this on each other, how to properly transfer the patient. So look at this for laboratory, and I could ask you questions on the exam. Do you think I could take wrong pictures? I could find them on or make my own and ask you, hey, what's wrong with this? But do you see this? Do you see this medical assistant helping this patient? Right? She's bending at. It goes bending at waist. Me personally, I'd get even a little bit lower, but we'll see. We'll look at all those techniques. This, I don't like how this is set up, but it's acceptable. This is a Mayo tray. This plate here can be sanitized. I don't like putting things like on the edge. Do you see, these are chucks or absorbable pads. There's a reason why there's a blue border on the edge. When I lay it all out, I make sure that none of my equipment is sticking out, because if it sticks out, it can either fall or get knocked over. And you could see here, where's the positioning of the assistant. It's away from the patient so that the doctor can get in there, but it's close enough where you can get things for the doctor, and again, put everything here on the lovely Mayo tray. Okay, named after the good Dr. Mayo. Alrighty. Now, remember, maybe I didn't state it in last week's lecture, but I've stated it at my other lectures. Because when you guys are studying for your exams, you could sit and just try to read everything over again, but that'd be silly. Use your textbook as a reference source, not as the, to go over word by word by word, and focus on, see these objectives? Don't you think I could figure out one question for each of these? And then that could be my exam, hint, hint, right? And you could also practice. There's these multiple choice questions at the end. And remember, the midterm is cumulative and it's multiple choice. And the more multiple choice examinations, the more multiple choice practice you have, the better you will feel and be during the actual exam. Remember, a prize fighter has to actually enter the ring. They can't just watch videos or work the bag all day or jump rope all day. They have to actually get in the ring daily, so that when they do get in the actual fight, so to make the analogy complete, when you do go into your exam, it's called conditional learning. You're already conditioned to a multiple choice question examination. And I prefer multiple choice for midterm and final, and I'm going to have multiple choice for midterm and final, because what do you think all your future exams are going to be? It's multiple choice. And I mean future exams that are really, really worth it and really count. Of course, your registration and registry exams, whether it be AMA, RMA, CCMA, RPT, any of the alphabet soup you can name. It's still the same format. So practicing the format, that's a better way to study. And you could do that via knowing what the objectives are. And that's easy. Just look either at the very beginning of the book or the very end of the book. So right here, it's a nice diagram for patient positions. Click on that. A nice picture here. Oh, it looks very, very similar. That's from their old textbook. How to set up an exam room. Nice little video. So let's see if I have what's in my physical examination notes. See, I took the objectives, and then I didn't put much. But look at those. Those are nice, and they're just bits and pieces. And remember, it's just an outline. What's due next week? Do quiz 2, discussion 2, and of course, everyone who is on the call right now, that's 1, 2, 3, 4 people, will get credit for today's lesson. And if you're watching this at home and you didn't attend this morning's lecture, kindly email me so that I can give you your makeup, or so you can do some work and get some credit. Ooh, what am I doing? Wrong. What am I doing? Okay. Share screen. Desktop. Okay. Now we're back. So it's at this point I'm going to